One out of three adults have prediabetes, and 1 out of 10 adults have type 2 diabetes. We have a lot of weight management clinics. So, as an endocrinologist, there are a lot of weight management clinics that I have run. And there are a lot of primary care physicians taking the aspect of preventive health care system and have annual health checkups. But what we've realized is that the burden of type 2 diabetes and lifestyle disorders keeps on rising. So there is this unanswered question, even for doctors, that what do we do? What is that missing link for us that we're not able to answer so far? Today, we have Dr. Todd Smith with us. He is a renowned expert in family medicine, and he's worked in a lot of leadership positions as a medical director. And currently, he's the medical director in one of the hospitals in the Twin Cities. I would like to welcome Dr. Todd Smith, and it's a delight to have you. And I'm looking forward to hearing a lot of your stories and insights from you. Welcome.
Well, thank you very much, Dr. Rohr, and I'm happy to be here today. Looking forward to the discussion. It's a topic that's very important and timely, as it always is, and a big problem in the US as well as across the world.
Yes, absolutely. So we'll dive right in into the topic, and I would like to hear your insights about um, what is the current preventive healthcare system, and is it really playing its true part in the United States?
The brief answer, I think, is no. Having been a family practice trained physician for longer than I care to admit, looking at 25 years or so, I have had large panels of patients, and I have diagnosed a lot of people with diabetes and managed people with diabetes. Preventive care in the US is in a really interesting position right now. I think that we have tried to do the best that we can with the resources that we have. I think that there's a big demand on primary care providers in the US, in this country, in this state. There's more demand than there is supply, first of all, of physicians and providers. And I think to do this, so we're going to get into this a little later, I think, but we're going to talk about different care models and how we can help physicians and providers to do what the preventative care that needs to be done. So right now, I don't think there's adequate time in a physician or a provider's schedule every day to really do the work that needs to be done to do it well. Do we do it? We do it, and we do it okay. I think there's a lot of room for improvement, and that's using using technology, using AI, using different roles that providers don't. When I say providers, I mean physicians and nurse practitioners and physician assistants, kind of prescribers. But the word we use a lot is providers, so that's what I mean when I say providers. That we can take some of that work off of providers that doesn't need to be provider work. So we work as a care team rather than just having the physician or provider have to do all of the work, because it just can't be done. There's not enough hours in the day.
You bring up a very good point, Dr. Smith, and then that's what my next point would be. Like, so there are these allotted time slots that we have for our patients. So if we talk about type 2 diabetes, and then they have chronic kidney disease and other complexities, yes, we have a little more time dedicated to them. But then we also have those people who are coming in with pre-diabetes and then just a higher weight. And then we have a little lesser time that we are allotted towards them. But then if we think about it, like for people who have pre-diabetes, they also have a lot of other psychosocial aspects that are involved in the development of their disease. And even if we talk about a higher weight, what was the thing that led them to in this situation is one question, but we're not able to cover all these aspects when we're talking about the time slot as such. So, what is your take on it, and how is it as doctors or even the patients coming to us that we can help them in our limited time slot, uh, you know, uh, uh, perspective like that we have? How is it that we could help them?
Yeah. That's the big quandary, right? I mean, you have, a primary care provider will have 20 people on their schedule in a day, and you get maybe 15, 20 minutes with them. You can't effectively diagnose, treat, prevent all of that in a 15, 20-minute visit. So it gets to be the challenge of, so you talked about kind of a broad swath there, but for someone we don't know has diabetes or pre-diabetes, you're doing their physical and it just happens to come up that, they have a family history, or, they're a little thirstier these days. And so you do some blood work. So that's step one, right? And we're diagnosing diabetes a lot more and earlier, which is good, but then that also leads to more patients that have diabetes that are on my panel as a primary care physician. So then I have more patients coming in for follow-ups. But traditionally, so you have old world thinking and new world thinking, let's just say. In the past, in my past, when I would manage these folks, I would see them every 3 months for maybe 20 minutes. We would talk about how things are going. We'd do an exam, we'd do labs, and off they go. And that's just repeated every quarter. Maybe a new way of thinking is we have multiple touch points to these patients in between those visits, right? So maybe they're virtual visits that the nurse gets on the line with them, a video call, and says, "How are you doing? Show me your insulin, how you draw it up. Make sure their technique is right. Show me your medicine bag that you have to make sure the medicines that we have on the record are the same. We have a dietitian, make contact with them. Tell me how, you're eating. Talk about a diet and exercise plan." So these are things that can't be done practically in a 15 to 20-minute doctor slash provider appointment. And if we're going to really effect good diabetic teaching, training, maintenance, prevention, treatment, it takes more than just one person seeing a person every 3 months for 15 or 20 minutes.
Absolutely. And you bring up a very good point that we need those multiple touch points. And there are a lot of disciplines that go into the aspect of the care of each person who has diabetes. So there may be an individual who has type 2 diabetes, but has a very strong craving sensation whenever they're upset. And this may go back to their past history where they didn't have their parents around with them, and the only comfort they found was food, and that's
Right.
why those cravings developed. Or maybe there is a lady who's work from home, she's busy all day, she doesn't have time for herself, she's not able to sleep well, and then she has to cook for her family, so she doesn't really have time for being very active, and then again she's losing on her sleep. So there are a lot of disciplines that are going in the care of diabetes management that we're missing on these usual appointments in these 15 to 20-minute slots. So that's why the role of multidisciplinary aspects or a care team that is needed for the management. And so how you already touched upon it, but how is it that we can actually implement it, or how is it without affecting the day-to-day routine of the individual, where they have to go to different individuals or specialists from here to there? How is it that they can imbibe it and better care for their diabetes?
Yeah, I think that that's a great question because, right, we don't want to be harassing these folks, every week with a video call or with a phone call or a doctor's visit, driving all over town. In my experience, I led primary care, and then just spent some time in IT at one of the organizations here in town. So I have a lot of thoughts about, using technology for this. I think there's a vast land out there that needs to be explored to use this. I think that we could use certainly applications on everybody carries around these smartphones now, practically everybody. Uh, let's try to find out how to use that technology. Let's try to figure out, are there wearables that people could, have at home that gives data through their smart device that uploads then to me and my care team daily weights. So we have a scale that's integrated to an app that sends me their weight, and I see if they go up 2 or 3 pounds in a day. That's going to send an alert to me as their provider. I think that if we can do things between those 90-day 15-minute visits that slide into the patient's regular day, that aren't obtrusive to them, and they don't need to remember, oh, I have to go onto the app and enter my weight now. That is everything we rely on for human memory is a
Yes.
potential for a sliding back. And so if we can make it easy, and we can make it unobtrusive, and we can make it something that the patient sees value for, right? That is how we can really do well. To your point, so much of chronic illness has an overlay of mental well-being and wellness, and I've seen it every day in my primary care practice. Folks who really have a good grasp mentally of their life, but also of their illness, and they get it, and they don't have confounding factors of, I don't know, a bad home life or financial stress or, all those other things that you mentioned, they do better. So how can we support those folks? And I've had patients say, when I've challenged them on that, say, let me get you to someone like a counselor or someone you can talk to. Oh, I don't have anything wrong with me. Mentally, I'm fine. There's a, and I will be very regionalistic here, but upper Midwest, very stoic people who don't feel like they need help with anything. No, I got it. I'm okay. And so you have to sort of get past that and help them to realize, oh, well, maybe I do need to talk about this and talk about my mental well-being. It's a huge part to me of any chronic illness, is someone's mental well-being. And that goes along with exercise then, which can also help with that, and eating right. So it's all a big package. And I think we're going to get into it a little bit too, but my focus always with these people was, I have medicines that'll bring your blood sugar down. I can give you medicine. I can give you insulin. I can give you metformin. I can give you these new GLP-1 drugs. But first, let's talk about exercise. Let's talk about eating better food. Let's talk about, doing these things that are going to have to be the base of the pyramid of treatment, right? Everybody with prediabetes, or really everybody, should be exercising regularly and eating better, clean eating, and all of that sort of thing, healthy mental well-being. That's the foundation you build any treatment of any chronic disease to me. Then you start talking about, okay, well, let's monitor the blood. Let's talk about medications. And so you build it on that sort of pyramid. At least in my mind, that's how I always would go about it.
You bring up another excellent point, and there's a lot of insights that you've already shared. But then, um, would you want to touch upon the indifference that people develop once they have developed type 2 diabetes? So initially they're in that phase of, right now I'm in an urgency that I need to be taken care of, because now from pre-diabetes I've reached a stage of type 2 diabetes,
Right.
and I'm like emotionally burnt out because now I have this condition. But after some time there's an indifference that sets in, and then
Yeah.
I don't really care, because whatever I do, it's not going to go away. That's
Right.
what how everybody kind of approaches it. So what is it from that aspect as doctors? Because when we keep telling them, okay, do this, do that, you need to fix your diet, you need to fix your lifestyle, you need to do this. I mean, we keep giving these advices, but ultimately they don't really register, is what we
Right.
feel like. We
Right.
just feel like, what is it that I can do to make you do these things? And I mean, if we relate it to ourselves also, like, it's very difficult to break a chain of habits that we have developed. So what is it that we should probably work on in terms of healthcare providers to help
Yep.
them?
That is so hard. And that's really kind of the million-dollar question. My experience, and we'll talk first about the why. It's easy to be bad. It's hard to be good. So bad food, I'll just call it bad food, is cheap and it's easy to get and it's everywhere. And now I can have really horrible junk food, Ubered to my doorstep, right? I don't even have to get off the couch. I don't have to go in the car. Where if I'm going to cook for my family and for me in a healthy way, I got to go to the market. I got to get fresh vegetables. I got to get, things that are healthier for me, lean protein, all of that. It's just easy to get on your phone and order Uber Eats from, McDonald's. Um, so it takes energy. It's that I got to put in energy to get up over that hill. And humans do respond to demonstrable effects, right? So if I can demonstrate to you, so Dr. Aurora, if you do this and you do that, now you come back in 3 months, your A1C is going to be lower next time if you do X, Y, and Z, and you're compliant and taking your medicines every day. And then they come back in 3 months and it's not. And then I say to them, well, tell me about your diet. Tell me, okay, that's not what we talked about. Tell me about your exercise. Oh, you really haven't done much exercise. Okay, I'm doing, I'm trying to help you, but I need you to help yourself. And so the next time they say, okay, I'm going to really buckle down and do it, and they do bring their A1C down, then they're like, oh, I guess this does kind of work. It's obviously it's not that simple, but what I tell people, I try to get to them early in their diagnosis to say this diabetes, think of it as a mountain or a hill in front of you. Okay, you're going to have to get to the top of it so you can try to get on the other side. At first, if you do it, that road is smooth and gentle. Okay, if you put it off, that hill's still there, but the road to the top gets steeper, right? So it's harder to get there if you don't start early. And once your A1C is 14, then help someone help you because I that's going to be really, really hard. And but on the other hand of that, just as what you talked about, you sometimes get to a point with a patient where they're like, I can't do it. I don't know what to do. I can't, nothing's working, nothing's helping. And then you're to the point of, okay, maybe I can get you to someone who can help mentally try to sort of, accept and adjust to this. So some people just don't want to hear it, and they're like, "I don't have diabetes. That's a bunch of baloney. I don't trust you, doctor." Well, okay, but here's the numbers, and this is what it is. I think families also play a big part. If you're the only one in your family eating like a diabetic, and nobody else is, that's going to be really, really hard. So the new diabetic has a lot of barriers that they have to work through. And I think as providers, you acknowledge that and you say, I get it, this person is very tough, but in their life, things are really hard. And they've always eaten this way all their life. And their mom and dad are probably diabetic, right? And it's a major, major shift to try to get them to shift. So it's not a great answer. I don't have all the answers, but I think working individually, and this is also another reason why we really have to start talking about care teams, because, if you have a nurse who can work with someone who really knows them really well, they can spend more time with them than I can as a provider. And I think if patients feel like we're invested in them, in the healthcare community, they'll respond better. And if we say to them, look, here's an app that really could help you. It's really easy to use. Here's how you log in, and I'm going to, help you set this up. Maybe you even have someone at the clinic who sets them up on an app, or two. And here's how you get a scale for very little money that can hook up to this app. So I think there are ways that we can work through that, but it's going to take different thinking about how we treat these folks.
Right. Very insightful. And I like the point that, if we have the family that's involved, then it becomes much easier. So, as
Huge.
yes, yes, because it's just one person dealing with it, and the one person is the one who's trying to do their best in eating healthy versus the other people in the family are not helping the
Yeah,
situation. So it has to be a family affair. And when it becomes a family affair, then the whole family's health actually ends up improving. So bang on, right?
exactly.
Yeah.
I To use an analogy or a similar thing, if I have someone who comes in and wants to stop smoking, my first thing is, does anyone else in the house smoke? Well, they have to quit too, because
Right.
you're not probably not going to have a big chance of success if the wife stops smoking, but the husband is still sitting there lighting up cigarettes right in her face. So, in the same way, it's a family effort to tackle this. And you're right, you elevate the health of everybody in the family if you start eating healthier and exercising, which is something you can do together. You can take the dog for a walk every day, and it's not a lot. The dog's happier, and eventually you both feel better too.
Yeah, yeah. I think it has to be a social affair. Like,
Yeah,
having friends,
yeah,
friends also does help.
right.
Like, this, yes, yeah.
Absolutely. Yeah.